طيب بسم الله والحمد لله والصلاة والسلام على رسول الله. اليوم إن شاء الله بنتكلم على موضوع الإندومتريوزز والأدينوميوزز. One of the common gynecological problems. It affects around 10% of the female in reproductive age. It can be so severe in some cases and it can cause chronic pelvic pain. معكم الدكتور محمد مازن ملك، استشاري طب النساء والولادة وتأخر الحمل من جامعة الملك عبد العزيز. بسم الله نبدأ. Okay, the objectives will be to understand the definition of endometriosis and adenomyosis, to explore the theories of its origin and pathophysiology, to understand the diagnosis of endometriosis, to be able to describe the clinical presentation of endometriosis and adenomyosis, and to outline the approach and management for this problem. Okay, here we can see the famous picture of ovarian cyst with some dark chocolate-like matter coming out of the cyst. It's very famous to describe it as chocolate cyst, هذا الcommon name للendometriosis. I'm sure many of you have heard about this before, chocolate cyst. So what is endometriosis? Endometriosis is defined as the presence of endometrial glands and stroma in extrauterine locations. زي ما انتم عارفين الاندوميتريوم اللي هو internal cavity حق اليوترس. If you find endometrial glands and stroma outside the endometrial cavity, this is by definition endometriosis. While adenomyosis is the growth of this endometrial gland and stroma into the uterine muscles. يعني نفس الجلاند والستروما تدخل جوة المصل حقت اليوترس نفسه.
Endo means internal and metrium means womb. So endometrium is the innermost layer of the womb, and endometriosis is where these endometrial cells grow outside of the womb. The female internal sex organs are the ovaries, which are the female gonads, the fallopian tubes, two muscular tubes that connect the ovaries to the uterus, which is a strong muscular sac that a fetus can develop in. It's a hollow organ that sits behind the urinary bladder and in front of the rectum. The top of the uterus, above the openings of the fallopian tubes, is called the fundus, and the region below the openings is called the uterine body. The uterus tapers down into the uterine isthmus and finally the cervix, which protrudes into the vagina. It's anchored to the sacrum by uterosacral ligaments, to the anterior body wall by round ligaments, and it's supported laterally by cardinal ligaments, as well as the mesometrium, which is a part of the broad ligament. The wall of the uterus has three layers: the perimetrium, which is a layer continuous with the lining of the peritoneal cavity, the myometrium, which is made of smooth muscle that contracts during childbirth to help push the baby out, and the endometrium, a mucosal layer that undergoes monthly cyclic changes. In endometriosis, the cells that make up the endometrium migrate and implant themselves in other parts of the body. Once there, they'll set up camp and start growing to form a mass of endometrial tissue. Most often, this affects the ovaries, fallopian tubes, and uterine ligaments. But it can also affect other structures in the pelvis and abdomen, like the perimetrium, the rectovaginal septum, the rectouterine pouch, also called the pouch of Douglas, and even the intestines or bladder. Although we're unsure of the exact cause of the endometrial cell migration, there are at least 5 main theories that try to explain this phenomenon. First, retrograde menstruation theory says that during menstruation, some blood-carrying endometrial cells will flow backwards into the fallopian tubes and implant into nearby tissue. Sometimes there could also be a patented fallopian tube, meaning there's an opening in it, so the adventurous endometrial cells could actually escape and travel to the other pelvic and abdominal structures. Now, because retrograde flow is much more common than endometriosis, other factors probably come into play. So the second theory is that there's a dysfunction with the immune system where B and T cells don't respond to endometrial implants and allow it to grow. Third, the metaplastic theory suggests that the cells of the peritoneum, which come from the same cell line as endometrial cells, can transform spontaneously into endometrial tissue. This theory explains how in rare cases, a woman that underwent a hysterectomy, where the uterus was surgically removed, can still develop endometriosis. The fourth and fifth theories are especially useful for explaining how endometrial implants show up in places like the lungs or heart. Benign metastases theory says that endometrial cells can travel to distant organs through the lymph and blood, while extrauterine stem cell theory says that the stem cells in the bone marrow differentiate into endometrial cells and then travel to other parts of the body. In addition to these proposed causes, there are some risk factors for developing endometriosis. These include a family history of endometriosis, never having been pregnant, early menarche, and late menopause. Now, whatever the cause, endometriosis implants are benign, so they don't grow out of control like cancerous cells. However, because they're functionally the same as the epithelial cells found within the uterus, they have the same estrogen receptor. So they go through the same proliferation, secretion, and menstruation cycle, just like the normal endometrial cells. But there are two key differences between normal endometrial cells and endometriosis implants. First, the implanted cells contain high levels of the enzyme aromatase, which allows them to produce their own estrogen. Second, the implanted cells release pro-inflammatory factors, which causes inflammation and scarring. These scars could cause adhesions, which is the binding of different organs or structures to each other, affecting their normal anatomical placement. Both the pro-inflammatory factors and estrogen also promote the growth of new blood vessels, which nourish the implant. Now, changes in hormone levels and the chronic inflammation will cause the implant to bleed, especially during menstruation. If the implant is on an ovary, it could form an endometriomas, or chocolate cysts, which contain the old dark blood and shed tissue. When these get too large, they'll rupture and spill their contents, resulting in a lot of pain and even more inflammation. Endometrioma cells also tend to develop mutations in certain genes, including PTEN and ARID1A, which increase the risk of developing ovarian carcinomas. The symptoms of endometriosis can be quite debilitating and are related to the location of the endometrial cells. Most commonly, endometriosis on the reproductive organs will cause pelvic pain, bleeding, dysmenorrhea, or painful menstruation, and dyspareunia, or painful sexual intercourse. If it involves the pouch of Douglas, a section of the peritoneum located between the rear wall of the uterus and the rectum, it can cause dyschezia, or pain with defecation. It can also cause urgent, frequent, and sometimes painful urination if it involves the bladder, and abdominal pain if it involves the intestines. All of these symptoms will often vary with the hormone changes throughout the menstrual cycle, and often gets worse during menstrual periods. About 30 to 40% of women with endometriosis are subfertile. The exact link between infertility and endometriosis isn't totally clear. It's believed that the inflammation that comes with endometriosis can damage or scar the reproductive structures, thus inhibiting the release of the egg or its movement through the fallopian tube. Damage to the uterus can also make the implantation of the gamete more difficult. The good news is that pregnancy is often still possible, depending on the severity of the endometriosis and the effectiveness of the treatment. The best way to diagnose endometriosis is through laparoscopy, and the diagnosis can be confirmed with a biopsy. Treatment is focused on managing pain, trying to limit the progression of the implants, and addressing the associated subfertility. Common hormonal medications that are used to treat pain include combined estrogen-progesterone oral contraceptive pills, which relieve pain through ovarian suppression, progesterone analogs like medroxyprogesterone and levonorgestrel, which inhibit growth of the endometrium, danazol, which is a steroid that inhibits mid-cycle surges of follicular-stimulating hormone and luteinizing hormone, and prevents steroidogenesis in the corpus luteum, and gonadotropin-releasing hormone modulators, which cause a decrease in estrogen levels. Surgical options are available for severe cases. If the woman still wants to have children, the surgery involves only excision of endometrial implants, endometriomas, and adhesions. If she has completed her childbearing, or if the pain is too debilitating, a hysterectomy and oophorectomy with excision of any other endometrial implants is done. Whatever the treatment, once menopause hits and hormone levels fall, the symptoms generally go away. Alright, as a quick recap, endometriosis is when cells of the endometrium grow outside the uterus. These cells follow the same hormonal cycle as normal endometrial tissue, including secretion and bleeding. This causes inflammation, scarring, adhesions, and endometriomas. Common symptoms include pelvic pain and bleeding that gets worse during menstruation, and infertility.
Thanks for watching. If you're interested in
Okay, perfect. So this slide, the idea behind this slide is just to show you that the endometrial implants or the endometriomas or the endometriotic lesions can happen anywhere in the pelvis. It could happen in the outer side of the uterus, it could happen in the fallopian tubes, in the ovary, in the deep areas, it could happen anywhere. And also you have to remember that, as it was explained in the previous slide, the severity of the symptoms are not related to the size of the endometriomas, which means you can have a big endometrioma or a big lesion and minimal symptoms. Sometimes the lesions are very small and superficial, and the patient might have severe pelvic pain or severe symptoms. Okay, here we can see, using laparoscopy, a superficial endometriotic area that looks like, you can describe it as, whitish powder with some blackish dots. This is the most common finding. This is stage 1 endometriosis. We find it a lot in the laparoscopy procedure for patients with pelvic pain or infertility. So this is an example of endometriotic lesion. Here is another example of laparoscopy again, showing severe, not severe, moderate adhesions in the posterior area and the cul-de-sac, obliterating the cul-de-sac. You can see the adhesions here. Also, there are some adhesions around the fallopian tube and the ovary on the left side. Another presentation of endometriosis. Here, this is a colposcopy. You can see clearly the cervix here. And you can see this black dot or black area. This is endometriosis. Sometimes we can see it even in the vaginal wall during speculum examination or during colposcopy. Again, cervix, endometriosis in the posterior fornix in the vagina. Another image with laparoscopy showing large ovarian cyst. It can be really huge for endometriomas. Okay, this slide shows a typical ultrasound appearance of endometrioma in the ultrasound. This one is transvaginal ultrasound, as you can tell from the image of the probe. And this is the ovary with large endometrioma. You can see it like a sandstorm, whitish lesions all around. All right. So this is a classical presentation of endometrioma. Of course, when we do ultrasound, it can live performance of the ultrasound, when you do it, you can press, you can see if there's adhesions to the surrounding tissue, you can run some Doppler around it to the blood supply, but this one is a classical appearance of endometrioma. And this one also another ultrasound image showing two endometriomas on both sides, and they are attached in the middle. Sometimes they call them kissing ovaries. And here in the Doppler we can see the blood supply is preserved around the lesions. So this is left endometrioma and right endometrioma, and here is the uterus, a transverse view. So with the improvement of ultrasound, مع تقدم أجهزة الالتراساوند وصرنا نسوي more ultrasound, more and more cases of endometriosis have been diagnosed by ultrasound. Of course, we cannot be 100% sure with the diagnosis of endometriosis unless we have histopathological diagnosis. You do a biopsy, you send it, and you find histopathological diagnosis. But you can diagnose it with high grade of confidence using the ultrasound and the presenting symptoms for the patients. As we do the ultrasound, we press on certain points and we see if there's any tender focal regions. هذه برضو تعطينا انطباع or give us an idea about the severity and the presence of endometriosis. Sometimes you can find if there's adhesions between those lesions and the surrounding tissues. So several techniques can help us to decide with certainty if there is endometriosis in the ultrasound. This is a case scenario in the ultrasound. They found the lesion, MRI confirmed ovarian cyst, did the laparoscopy, found the cyst, excised, sent for pathology to confirm a diagnosis. هذا الكلاسيكال كده journey في الكيسز حقت endometriosis. The prevalence of endometriosis is estimated to be around 10% of women in reproductive age, and this percentage is actually higher than this in females with infertility or in pelvic pain. We also are diagnosing endometriosis more and more nowadays, especially with the advancement of the ultrasound and performing more and more laparoscopy procedures. There is a strong genetic predisposition as evident by running of endometriosis in the families. So oftentimes we find a patient with endometriosis, you will find some relative like her mother or sister with the same condition, indicating that there is some genetic predisposition. Okay, this is a common question. They always ask about what are the common sites of endometriosis. So common sites of endometriosis in decreasing order of frequency. Number one is it the ovary. Number two is in cul-de-sac. And number three is in uterosacral ligament. You have to remember that, as we said, endometriosis can happen anywhere. In the pelvis, in the abdomen, in the chest, around the lung, anywhere you can find endometriosis. But these are the most common sites. We also oftentimes talk about stage of endometriosis. We usually stage the endometriosis into 4 stages, starting from stage 1, which is the minimal endometriosis, in which you have superficial small lesions. The staging usually is a bit complicated system, but to summarize it or to simplify it, it depends on the size of the lesion, the distribution, and the presence of adhesions. So if you have like minimal small lesions distributed in the pelvis with no adhesions, this is usually stage 1. Stage 2 it is when we have a slightly bigger lesions and some form of adhesions. Stage 3 is moderate when you have larger lesions and you have more adhesions in the pelvis. Stage 4 when you have large endometriomas with severe adhesions and obliteration of the pelvic organs. This is an example of the scoring system that's used by the American Fertility Society. Again, it depends on how deep, superficial or deep, the lesions, and also the size of the lesions, less than 1 centimeter, 1 to 3 centimeter, or more than 3 centimeter, and the adhesions. Okay, for the pathogenesis, we have multiple theories explaining the endometriosis. The 3 most common theories being, number 1, the retrograde menstruations theory of Sampson. Number 2, the Mullerian metaplasia of Meyer, in which indicates that endometriosis results from metaplastic transformation of peritoneal mesothelium into endometrium under the influence of certain generally unidentified stimuli. And this hypothesis or theory explains the presence of endometriosis in far away areas away from the retrograde and also in patients with hysterectomy. The third theory is the lymphatic spread of Halban. Also, there is some immunological factor that cannot be excluded. There is some immunological alterations in those patients. And also there is the genetic component of endometriosis. Endometriomas of the ovary are cysts filled with thick chocolate-colored fluid that sometimes has a black color and tarry consistency. It's the most common, or the most stigmatic feature of endometriosis when you talk about chocolate cyst, big ovarian cyst with dark matter like this. Of course, every month with the menstruation, there's more shedding inside those cysts, and with time, it becomes more and more darker. As for the histopathology, I'll just skip this video. Histopathology, we need to have 2 of 4 characteristics that need to be found in the sample, in the histopathology sample, to confirm endometrioma. Number 1, you need to have endometrial epithelium, you need to have endometrial glands, endometrial stroma, and hemosiderin-laden macrophages. If you have 2 out of these 4, then you have endometriosis. Of course, it needs to be present outside the endometrial cavity. As for the presentations, usually patients with endometriosis have 3 presentations. Number 1, patients might have pain. Chronic pelvic pain, it can present as dysmenorrhea, which is painful menstruation, dyspareunia, which is painful intercourse, or dyschezia, which is painful passing stool. So pain is one of the most common presentations. The second presentation is infertility, in which patient will present with delayed conception, or the patient might be asymptomatic and we find the endometrioma incidentally in ultrasound or during examination. So either asymptomatic, they can present with pain, or they can present with infertility, or sometimes pain with infertility. When we talk about characteristic triad of symptoms, we are talking about dysmenorrhea, dyspareunia, and dyschezia. And there is no clear relationship between the stage of endometriosis and the frequency and the severity of pain symptoms, which means sometimes you might have really superficial and small lesions and the patient might have really severe pain. Sometimes it's the opposite. You might have big cysts, severe adhesions, and the patient might be asymptomatic. Sometimes also patients can complain of premenstrual and postmenstrual spotting. One of the differential diagnoses of this spotting is to have endometriosis. So to diagnose endometriosis in the history, as we said, we can have pelvic pain or infertility. During examination, after you do thorough examination, the pelvis, abdomen and pelvis, you will find sometimes firm or fixed tender adnexal mass. Sometimes you might find no masses, but you will find tender nodularity during the examination, especially in the area of cul-de-sac and the uterosacral ligament. That's why during assessment of patients with pelvic pain or infertility, if you perform physical examination, you look for cysts, you look for tender masses, you look for some fixed lesions, and oftentimes we perform vaginal with rectal examination to assess the area of uterosacral ligament and the cul-de-sac. You might find tender nodularities there. The other way we do it, especially I do it a lot, during performing the transvaginal pelvic ultrasound using the probe, I try to find if there's any tender points. And sometimes you can see small cysts that are really tender during ultrasound examination. And this usually gives you high suspicion of endometriosis. Of course, if you do history and examination, you need to perform ultrasound and MRI to confirm your diagnosis in which you can find the lesions. Interesting finding is that some patients with endometriosis, serum level of CA125 is frequently elevated in those patients. That's why patients with CA125, especially premenopausal, we don't think right away of cancer. We think first endometriosis. Any peritoneal irritation can give you increased CA125. So there's wide differential diagnosis. We worry about ovarian cancer if CA125 is really high, and if there is classical features in the ultrasound, the so-called risk of malignancy index, RMI. So ultrasound features high CA125 and the patient being postmenopausal, we worry about ovarian cancer. Young patient, pelvic pain, slightly elevated CA125 usually is related to endometriosis. So however, the positive predictive value of CA125 for detecting of endometriosis is low. That's why we don't rely on CA125 to diagnose endometriosis, but it's incidental finding in many cases of endometriosis. You might find CA125 elevated. As all of you know, the positive predictive value is the probability that following a positive test result that the individual will truly have that specific disease. So the definitive diagnosis for endometriosis, gross and histologic findings obtained during laparoscopy or laparotomy, or sometimes during cyst aspiration or during IVF egg collection procedure. You can drain the endometrioma and send it for histopathology to confirm the diagnosis. Okay, now we'll talk about the management of endometriosis. So as we said, we always talk about general principles in managing any disorder. Number one, we need to improve the quality of the patient life, meaning you need to relieve their symptoms, manage their symptoms. You need to respect their wishes. And we always talk about lifestyle modifications and improvement of the quality of life. The aims for management in the patient with endometriosis, of course, it depends on the symptoms. So if the patient is presenting with pelvic pain, we focus on managing the pain. If the patient presents with infertility, then we focus on managing the infertility. Sometimes you can have both of them, so you need to manage both at the same time. And also, in addition to relieving the patient's symptoms, we need to focus on preventing or reducing the risk of disease progression in the cases of endometriosis. As for the pain, we usually start the patient as first line of management by using non-steroidal anti-inflammatories. Non-steroidal anti-inflammatories, as you know, we have to warn the patient about using them with plenty of fluid and using them with food, as they can cause some gastric upset, they can cause peptic ulcer, they can cause renal impairment. That's why they have to have a lot of fluids. They need to take it only when they have severe pain, and they should not use it for long or prolonged times to avoid these complications. We oftentimes can use combined birth control pills for patients with endometriosis. The reason is number one, the estrogen, low dose of estrogen and OCPs will suppress the FSH and LH activity, leading to suppression of ovulation. And the progestin part of the birth control pills will help to shrink the endometriotic lesions. So, a woman with pelvic pain who does not wish to conceive, we always start them on the birth control pills as the first line treatment on top of the non-steroidals. The other thing, the use of combined contraceptive pills will reduce the demand and the need for the non-steroidal anti-inflammatory drugs. As we said, this is needed to prevent the long-term complications of the NSAIDs. Second line of treatment is GnRH agonist to suppress the GnRH and to put the patient on transient menopausal state. This can help to alleviate their symptoms, but we need to be careful not to use it for prolonged times more than 6 months, as this might affect the bone health for the patient. We can use higher doses of progestin without estrogen. For example, Dienogest is also used to control the pelvic pain with huge success. And lastly is the use of weak androgen danazol to shrink the endometriotic lesion and to control the pelvic pain. Problem with weak androgens like danazol is that it can give you androgenic side effect, can give you symptoms of hyperandrogenism. It can lead in some cases to deepening of the voice, which is unfortunately irreversible. That's why we really avoid using danazol nowadays in treating pelvic pain or endometriosis. Surgical treatment of endometriosis consists mainly of laparoscopy. The aim of those treatments is number one, to excise all the endometriotic lesions, so excision of endometriomas and endometriotic lesions, to do adhesiolysis to remove all the adhesions and to make sure that the fallopian tubes are open, patent, and functional. And in terminal cases or cases who completed their childbirth, we can perform total hysterectomy with bilateral salpingo-oophorectomy as the ultimate treatment for cases of endometriosis. For patients with infertility and endometriosis, we always talk about completing full infertility workup. As we talked in previous lectures, in the PCOS and infertility lectures, we have to perform full assessment. Infertility means you have to assess both male and female. You cannot rely on one diagnosis starting managing without checking the other partner. So we have to perform semen analysis, you have to assess the ovarian reserve, you have to assess the hormonal profile, meaning TSH and prolactin, making sure that FSH, LH are within normal. Then you have to ensure that the patient is ovulatory, either by the history of having regular cycles, by ultrasound, checking the follicles, making sure they are growing and ovulating, or by mid-luteal progesterone, making sure that the progesterone is high during the mid-luteal phase. And of course, it's very important to perform pelvic ultrasound to assess the uterus and the ovaries and to check for any endometriomas or lesions. And also we perform hysterosalpingogram or saline infusion sonohysterogram to assess for tubal patency. After completing the workup, if we confirm the diagnosis of endometriosis, then the best line of management usually is in vitro fertilization. So as you know, the idea of in vitro fertilization or in vitro fertilization with intracytoplasmic sperm injection, IVF with ICSI, the idea is to fertilize the oocyte by the sperm in the lab, outside the body. So in cases of endometriosis, the patient will have most likely chronic inflammatory changes in the pelvis. They might have tubal block, they might have fallopian tube dysfunction. So they are perfect candidates for in vitro fertilization. IVF is usually very successful, and the success rate of IVF in the endometriosis cases is similar to no endometriosis in the same age group. So endometriosis is very successful in treating infertility for patients with endometriosis. Traditionally, long time ago, we used to go for laparoscopy as first-line treatment, and then we asked the patient to try, or the couple to try to conceive for a year after the laparoscopy. Problem with that is that we found the success not to be as high as in vitro fertilization. That's number one. Number two, the procedure with the laparoscopy sometimes is difficult. You might end up by having complications. You might end up by affecting the ovarian reserve in case there was severe adhesions or large endometriomas. This might affect the patient negatively. So now we are moving more and more towards doing IVF for those couples rather than relying only on laparoscopy and wasting their time. So just to summarize, in vitro fertilization is very successful in endometriosis cases. Now it's gaining more popularity. It's our first choice for managing couples with infertility. Quick review, in IVF patients, we start by ovarian stimulation with the gonadotropins, the injections. Usually I take it starting from the early follicular phase. The duration usually is around 10 to 12 days of stimulation until the follicles reach maturation size. Then we provide them with a trigger shot. We perform the egg collection 36 hours after the trigger shot. We take the sample from the husband, prepare the sample, do the fertilization, incubate the embryos to allow them to develop. We like them to develop until blastocyst stage in day 5, and then at that time we do the embryo transfer. After the embryo transfer, we provide them with progesterone supplement to make sure and to ensure there is a good environment for the embryos and to support the pregnancy until the first 12 weeks. Okay, perfect. That was for IVF and endometriosis. Okay, adenomyosis is the other topic. It's defined as the extension of endometrial glands and stroma into the atrial musculature more than 2.5 millimeters beneath the basalis layer. So there is the basalis layer connecting the endometrium and the myometrium. If there is any break in that layer, you might have invasion of the endometrial gland and stroma inside the myometrium, leading to adenomyosis. Here is a diagram that shows the extent and the different severities of adenomyosis. That's the endometrium. You can see here in the picture, it's already invading the muscle. It can invade more. It can be global invasion, or it could be only focal invasion in the myometrium. The prevalence, up to 60% of women in their 40s might have some form of adenomyosis. So typically we're talking about patients who are multiparous in their late reproductive age, in late 40s, who develop this adenomyosis. About 15% of patients with adenomyosis will have associated endometriosis as well. So the classical presentation, classical picture, women in their late 40s having dysmenorrhea, having pelvic pressure, pelvic pain. When you do ultrasound or you do physical examination, you will find enlarged globular uterus, or sometimes you might find focal lesions inside the myometrium, indicating adenomyosis. So the gross appearance of the uterus consists of diffuse enlargement with a thickened myometrium containing characteristic glandular irregularities with implants containing both glandular tissue and stroma. So when you examine the patient, usually the uterus is really enlarged and really tender, or sometimes might have just focal areas of tenderness. Under the slide, in the histopathology, you will find myometrium, and you'll find the endometrium in the endometrial area, and you'll find some endometrial focuses or foci inside the myometrium, indicating adenomyosis. This is a gross appearance of sample or of hysterectomy uterus, showing the glands and the stroma of the myometrium, of the endometrium invading inside the myometrium. You see, هذه كلها lesions of adenomyosis هنا وهنا. Again, hugely enlarged uterus with diffuse infiltration inside the myometrium. Wall is thickened and contains small hemorrhagic foci. MRI can confirm the diagnosis in many cases in which you find really enlarged uterus with thickened myometrial wall, characteristic of adenomyosis. So symptoms, it ranges from asymptomatic to severe secondary dysmenorrhea and heavy menstrual bleeding. Sometimes they might present, by the way, with infertility, the patients with adenomyosis. They have altered endometrial function, and sometimes it's really difficult to get them pregnant, even with IVF, in cases of severe adenomyosis. Signs, typical sign is symmetrically enlarged and somewhat buggy and tender uterus. Okay, what are the options for management? Again, management depends on the patient's symptoms. If the patient is presented mostly with pelvic pain, then we can use non-steroidal anti-inflammatories. We can use combined birth control pills to regulate the cycle and to reduce the pelvic pain by reducing the activity and the inflammatory changes in the myometrium as the effect of progesterone. We can use only progesterone only pills, continuous or cyclical. It can help to diminish the pelvic pain. We can use progesterone releasing intrauterine devices like Mirena. It also might reduce the pelvic pain and the menorrhagia in some cases, although it's not really typically used, especially for patients who might have pelvic pain. Sometimes they might resist having intrauterine device. It might sometimes exacerbate their symptoms, but it's one of the treatment options. And lastly, the last treatment is hysterectomy. Okay, this is an exercise for you guys. I want you to exercise an OSCE station in which you have 45 years old lady, para 5, aorta 1, presented with new onset of heavy prolonged periods and deep dyspareunia. So what would be your approach? What would be your history, examination? What would you order for investigations? And let's say you landed up with diagnosis of adenomyosis, what would be your treatment options? That was the presentation. We talked about adenomyosis and endometriosis. I hope you enjoyed it. This was Dr. Muhammad Malak. Thank you so much.